They come here, they're young, they may be at some level contemplated dying for their country, but they maybe didn't contemplate what it would be like to be severely wounded and disabled for the rest of their life. And so there's an adjustment, there's a process, there's a respect for their feelings, that they're going to have to walk through their feelings. And there's lots of kind of techniques and theories about how to help the patient, support the patient and their family, because that's the number one predictor of a good outcome, is that the patient has a good support system. Some of that is a good unit with great leadership, a good family, good friends, some comrades that rally around them. But we are therapists and staff at the center. We're a vital component in that support system for them. So some of it is just giving them the emotional space and support for them to feel the feelings and figure some things out. But I will tell you one thing that works very, very well that we do here, and that's use the peer visitation system. So I can say lots of different things and use a lot of positive comments and you know, years of working with amputees. I've got a couple tricks up my sleeve for that, but that may not be as effective as finding another amputee who's been successful using a prosthesis that can walk into the room and get the patient thinking, wow, now there's somebody that looks like me. They have missing an arm, same as me, and look at them. They're wearing a business suit, they have a job, they're walking in here, they're putting their prosthesis in their pocket like it's an arm, acting very natural, and the patient, something goes on in the patient's mind that says, I can do this too, or I now have a role model, I want to be like that. We have the computer-assisted rehab environment, the Karen system, which is top of the line, virtual reality. We can even simulate ascent in there. So at 300 degrees around them, they are as immersed as they could be, short of putting a door on that thing. They're in a virtual environment, and there's 55 different scenarios that go on that screen that allow them, and the floor moves, and we're measuring everything, and they're really there wherever we make there be for them. It's very important because from the research side, we're gathering all sorts of metrics on them, looking at biomechanical data, seeing how they respond psychologically, how do they respond when we simulate a war environment again for them. And is very important, gives the researchers data, gives the clinicians data, and sometimes most importantly, it gives the patient data about their own performance. When you start messing with the floor underneath them, you start changing scenarios in front of them, watching to see how their balance is. That's great feedback for them. But I'm sort of old school, and I think that nothing simulated will ever be as good as the actual reality. And of course, the value of the simulated is we can simulate all sorts of things that in reality we can't expose them to. It would be impossible. But the majority of the time is spent working on balance in the real world and walking up the stairs. We don't simulate that. We actually will take the real stairs. And for the upper extremity people, it may be great to simulate certain things, but there's nothing like actually having real objects in your hands to work with. Going into the kitchen, working with real utensils and trying to cook an actual real meal. These things are best not simulated. So there's a balance, and just having wisdom to know at what point in somebody's treatment should you be using some simulation versus should you be using some reality. That's a question that's near and dear to my heart too, because we have to treat the total person. We have lots of technology to treat the physical person. And but we need to treat the psyche, the emotional, the spiritual, the relational, the social. They all have to be recognized as relevant components to the person in order for us to do a full recovery. And it's interesting to know that what happens is when you hit on some of those other pieces of the person, those other components, then replacing their limb with a prosthesis almost kind of fades away because there's a wholeness about them emotionally, spiritually, relationally, that it's almost like the body image changes on them and you just look at them totally different. And then you put the prosthesis on and you say, okay, physically you're whole again, but we've been working on making you whole in a deeper sense. Doesn't always happen that way. Of course, there's places where there's resistance and lots of things to be worked through. And I don't know that it's ever even, I think it's kind of a lifetime journey, just like anything. I often make the comparison of limb loss and acceptance of that, similar to an addict or an alcoholic who has to walk through their recovery every single day. Every single day, they have to acknowledge that they're powerless to an addiction and that they accept their lot in life. And each day, they take it one day at a time. They have a fellowship of friends, fellow alcoholics or addicts in recovery, that they lean on for support, that they can call. They have to build that network. But if they're looking for sanity and sobriety, then they have a certain way they have to be. And the same with our patients with limb loss. If they're seeking wholeness, emotional, spiritual, relational wholeness, they have a certain thing they have to do too. They have to live out a lifetime program across the board. Once we do that, and if we do that well, then the family business stuff falls into place. Then the wife may not see that a husband is missing both legs because to her, he's whole. And the prosthetic legs just allow him to get up out of the wheelchair and walk.